Thank you everyone for being here. It's actually splendid to see so many people come to a lunch discussion on the economics of prevention. From my perspective, as now somebody who's able to indulge in thinking about policy and health in particular, it seems to me that we need to take this more than seriously. In fact, I was thinking as I was listening to David Hurd introduce the session, in 1982, the World Health Organization committed through the Ottawa Charter to health in all policies, recognising long before health systems have even got there that health is the consequence of all policies. It is not the business of health policy. I think I'd like you to think today, as we have this discussion, about whether or not we should now change that to the economics of prevention should be in all policies. Because at the end of the day, as we've heard and as we will hear, prevention in all policies affects the health and well-being, not just of our population, individuals within it, but our communities and most of all, our economy. So, I look forward to the discussion and invite Terry to start first, if you wouldn't mind.
Thanks, Rosemary. Hi, everyone. Thanks again to the organisers for the chance to be part of this. Just in case you hadn't noticed, the organisers have chosen two of the really, at a global level, outstanding Australian achievements in prevention as case studies for this discussion. One, I think, and I'll argue in a minute, is in the vaccination immunisation area, and the other is in road safety, which you're going to hear about, the TAC's world-leading initiative based on a return on investment argument, as you'll hear, and I use your experience to teach my students all the time because it is just a wonderful, rational basis for a huge public health achievement over a long period of time. And in immunisation too, Australia has really been a leader in getting its act together and organised, frankly, from a fairly low base, because in the late 80s, it was a bit of a mess. We had a national program of immunisation that consisted of nothing being done nationally. It was all done at the state level. Different states were paying different prices for exactly the same vaccines. There was a sort of a national schedule which might or might not have been adhered to by the states. In the early 90s, we had the first national immunisation strategy. Shortly after that, the establishment of something pivotal to the success of what's happened since was the establishment of the Australian Childhood Immunisation Register, which meant that every single child from birth was registered in order to keep track of whether they were up to date or not. And in terms of program quality control, innovation and so forth, incentivisation of health service providers and others was absolutely fundamental. And then later in the late 90s, the Liberal government with the first health minister who sat on the basically the economic advisory internal cabinet position, Michael Woolridge, was responsible for what was called a 7-point plan. And that really changed up very dramatically government's role in both coordinating funding and innovation within the whole immunisation framework. And then later in 2005, relevant to David's discussion earlier and also to the GSK monograph, which is being released today, the mechanism that had been used very successfully in Australia for drugs for national free public access, the Pharmaceutical Benefits Scheme, PBS, vaccines were moved into that scheme through what's called the Pharmaceutical Benefits Advisory Committee to make decisions to recommend to government or not on the purchase for public free funding of vaccines for a national program. And that's been extremely successful. So the first thing that I want to say, and I've said to a number of journalists in the last couple of days, is we don't have something that's broken. We have something which is superb, but we do believe it could be better. And that's the basis, I think, of the argument that's being made by GSK and also by some of the other major companies of excellence, GSK being one of them around the world, who are vaccine producers. So in terms of this discussion start, I wanted to highlight what I've called 5 paradoxes that relate to prevention within vaccines that help understand then the decision-making that flows from those paradoxes and where some of these difficulties are. The first is the simple prevention paradox, that when prevention's working, nothing's happening. It's different when you've got an outbreak of something or a crisis of an epidemic of diabetes or non-communicable disease. If nothing's happening, we know it's working, and then the dangers around that is that we don't do anything because we become lax. And there are many periods of our history when that has been the case, when we've taken our foot off the pedal and things have started to unravel. One of the problems with vaccines is that we've now got an armamentarium of superb vaccines, a lot the result of the molecular revolution that's happened in science in the last 15 or 20 years. And some of those prevention capabilities are for diseases that are not necessarily manifest at the moment, but might become manifest next year or the year after or in 5 years' time, or are diseases that wax and wane over time. So, for example, flu. This year we have a particularly bad year for flu so far. We're hoping that it's going to plateau, but we don't know yet. But out of the blue, for reasons that are not yet fully understood, all of a sudden we've got 2, 3, 4, 5 times more disease than we thought we'd have. Entirely unpredictable. And yet the decisions that we make on funding products are based on the epidemiology of a particular disease or condition today. In 2 or 3 years' time, in order to get to a point where the justification for that investment might reach a threshold, many people may have to die or may have to have serious illness in order for us to be persuaded to use an intervention we've already got in our hands to save those lives. So lives have to be lost before we can get to that point of making that decision. That is the paradox. And that's a fundamental issue for vaccines. Meningococcal disease is another example, which we may get into later. The second issue is to do with some of the technical aspects of economic analysis. So the first is that the evidence for funding is constrained by this unrealisable certainty. So other than the variation in disease over time, another aspect of that is what's called herd immunity. So the extent to which those of us who are immunised protect those in our community who are not immunised is what the herd immunity phenomenon is. Herd immunity is simply you're reducing the level of circulating disease, virus or bacteria, and because you're immunised, and because that's not circulating, those who are not immunised are not exposed to it, and therefore they also don't get that disease. So there are many examples where this has had a dramatic effect in the community, where babies and children have been immunised, and the elderly have not got the disease because the children are the propagators of that disease. So that too is an uncertainty. The paradox here is that until you've introduced a vaccine into the whole community, you can't actually measure herd immunity. And you can't introduce it into the whole community in some frameworks, like the PBAC, until you've got the evidence for that herd immunity. So you're stuck. This is the catch-22. You can estimate what it might be, and you can have an authorising authority that might or might not accept the level of uncertainty based on that estimate. But that is another example of a paradox. The third is the willingness to pay. At the moment, formally, the community's valuation, if you like, of an intervention, a vaccine, is not formally codified in terms of a metric that feeds into a cost-effectiveness framework. What's happened de facto, though, and you'll see this, the state governments have provided the evidence that this is an important determinant, because in a number of vaccines over the last 5 years, state governments have been pressured by their own communities. They're much more proximal to the voters because they're the service providers, not the Commonwealth. And so in the case of a few conditions, one is whooping cough or pertussis. So vaccinating pregnant women to protect their newborns up to the age of 3 months was funded by a number of states before finally, only in the last year, it is now funded through the NIP. And so this started in New South Wales, where there was a celebrated case of a newborn who had died from whooping cough, and it really became a cause célèbre within the political space, and then led to funding initially in New South Wales, then Victoria and the other states, and everyone followed, and now finally, some years later, by the Commonwealth through the NIP. Another is childhood influenza. Similarly, the states have picked up the funding for that. Only this year, the Minister has announced finally that it is now approved for under 5-year-olds to be funded for flu vaccine. Another is meningococcal disease. So I mentioned before about changing over time the epidemiology. Meningococcal type W, which is a subtype of meningococcal disease. We all heard of C and type B, but W has just appeared out of nowhere and has become all of a sudden a substantial proportion of disease. We've had the vaccine for W for a number of years, But we haven't been using it because we've said, this is the paradox again, there's no W disease, therefore we don't need to use it, we'll just use the C vaccine. And so again, a number of the states introduced programs to protect against W using a 4-valent A, C, Y and W all-in-one vaccine. And then finally the Commonwealth will come on board through the NIP, and now it is funded under the NIP at 12 months of age. And then the fifth category is a vaccine which isn't yet funded, which is against meningococcal B, and that too is a very important life-threatening disease with lifelong consequences for disability. That at the moment in one state has been funded, but has not yet reached threshold within the NIP. So that's an important, that willingness to pay and how we codify that is an area for those of you who are economists in the room, something which I think we need to pay attention to, and that should be part of study and debate about how and whether we find a way to let consumers have a view about their willingness to pay other than the sort of formal econometric analysis. And fourthly is there are some technical issues around the current economic framework which is in the GSK document. The two principal things, one is this issue of societal versus payer perspectives for the costs and the benefits side of what happens with vaccines. So this is, David mentioned in his talk, the cost of lost employment or time off work or NDIS payments, those sorts of things which occur downstream as an impact of having had a particular preventable disease. In some jurisdictions, they are both highly valued and admissible in calculating it. In Australia, theoretically it is admissible, but in practice what happens, the quality of that evidence is often judged to be not really strong enough to be able to be added to that equation. And then what's called the discount rate, again, the economists will understand the extent to which expenditure now produces future savings is reflected in the calculation of the economic model. It's a very powerful determinant of what the outcome of that economic model is. At the moment, we're using a discount rate which is substantially higher than a number of other more progressive countries, including the UK, where a lifelong benefit of a vaccine is, if you like, properly reflected in a lower discount rate. And then finally, and this is something that companies may not be happy with, but one interesting aspect of how the onus of proof works in Australia is the companies themselves have the burden of proof to show that their vaccine is cost effective. And you might argue that that's okay for a drug for a particular target population, and particularly when there are thousands of different drugs in different conditions. But for a whole population of healthy and well adults or children, you could also argue that that burden of proof should be on government. At the moment, the companies have to produce a dossier which is submitted to the PBAC for their evaluation. So the companies pay for and do that economic analysis. The PBAC takes it apart. They subcontract that out to a number of academic and other entities to take it apart and criticise it and so forth, and then put it back together again. But Australia is pretty unique in the way in which this model works. In most other countries, it's actually the government themselves or an agency of government that does it. In the UK, it's NICE. In the United States, it's the Centres for Disease Control and other academic entities that do this. So it might or might not be a good thing, but I think it's not something that we've looked at fundamentally, and I think this is an area where we do need to have some policy analysis and look at the benefits. We're a small country. Having the capacity to do that inside government might actually be a significant rate limiter because we're just not big enough to maintain the level of skill capability you need to do that at scale. But nonetheless, I think this is an important issue that discriminates us. So I just want to finish by saying that I applaud GSK and what they've done in the vaccine space in initiating this discussion. In the foreword to their document that I've written independently, by the way, and I wrote it, they didn't, I say what I mean, and that is that I do think that the last sentence of that, as you read it, we need to have a debate that involves everyone, the manufacturers, government, academia, at all levels of government, by the way, not just the federal government, but importantly, consumers. They need to have a voice in this and how we actually go forward with better policy than what we already have, which is good, but we believe it could be much better. Thank you.
Thanks, Terry. And I'd like to just pick up on your comment about discounts and the value of lives, and I think that's what we're going to hear from Tony about, because we don't. In so much of what we do, we don't value the impact, cost and the consequence on the individual, let alone their environment and the ripple effect out to communities, workplaces, schools, and the economy, and the value of a life in prevention, particularly in understanding health for all, I think is going to be a really important addition to this debate. Over to you, Tony.
Thank you. Thanks, Rosemary, and thanks, Terry, for some kind words. And I think from a road safety perspective, we've come a long way over many years, but we still feel that the journey's only just begun and there's a lot more challenges. I think the benefit, and I thank CEDA for the invitation today, is of getting together and being sort of the rose between the thorns maybe, as something of an outlier with the theory, is just how important that having good conversations, a good debate, and learning from others outside of your normal sphere is so powerful in terms of what we're learning. So if I may, I'll take you on a little journey of what the TAC has been going through in the last couple of years, which really resonates that. So with TAC, we're a social insurer, and what that means is we value life. In everything we do and all the decisions we make, we put the value of the Victorian community at the centre. For our staff, the most important value that we have is that we value life. And so that again resonates with the decision making that our staff are doing as well. The TAC's long-term aim is to see that there's no one killed or seriously injured on our roads. It's a very ambitious strategy, and we're aiming by 2050 for that to come true. What we can see though is that is a huge departure from where we have been in the past. I guess in the past we've always taken an economic rationalist sort of view of things in terms of getting the cost benefit. So we look at reducing road trauma as an investment. So where's the cost of undertaking the preventative measures, whether it's spending money on infrastructure, education, enforcements, roadside breath testing, those sorts of things. Weighed up against the costs and societal costs of those injuries and the impact of road trauma. It's not to say we're not still looking at the value of life in those, but it always had to come back to the payback. Was there a payback for what was being invested? In that process, we used the what we called BCR, which is the benefit to cost ratio, which was very common in road safety. And we've seen over the last few years that we have what we call the BCR for our infrastructure program. So anyone that's driven on Victorian roads in the last few years would see all the wire rope barriers that are around, and that's giving us on an economic basis a 3-to-1 return. I think the most recent stats are over the last 12 months there's been 300,000 hits on those wire rope barriers in a year. So that doesn't mean that there's 300,000 lives that have been saved, but there's 300,000 impact or injuries that are much less severe than they would have been. So that's a great impact for us. But that's great. An investment in infrastructure and then safer cars is also very important in what we do, but it's also very expensive. So what we need to do is also get the community behind what we're doing. So more recently in Victoria, we've followed what the Northern European and particularly Sweden are doing in their approach where every human life is assumed to be sacrosanct. And decisions around design and operation of the transport system are made with safety as a key consideration. Whereas in the past, safety would have been one of the considerations along with mobility, environmental issues and those sorts of things. We're putting in front of that the value of someone's life. To do that though, and to move forward, it takes political leadership. Unfortunately in Victoria, we've had the backing of the state government and our partners pulling that together, and that's so important. The Swedish Parliament openly debated the move to adopt a towards zero vision in 1997, and in doing so, made a very public statement to the community that it was valuing their lives. Now, wouldn't that be a great position if we could do that, if it's not just in road safety, but in other aspects of what we're talking about in health and people's lives? And if I may, I'll just give you a short example of something that really resonates to help bring together what I'm talking about in terms of that community sentiment. So in Victoria, we knew that the community believed that there was some level of road trauma that was inevitable. That to have a modern and efficient road system, some people would have to be killed or injured on our roads. So, what was the acceptable level? So we wanted to let the community know that we were not accepting that as a reality anymore. And we wanted to reset the community agenda in relation to how we thought and talked about road trauma. Now, some of you remember our road safety campaign. We called it our Man on the Street. So we had our man, Francisco, who was randomly picked off the street and asked a question about, in the previous year there was 250 lives lost on our roads. What would you think would be an acceptable number for us to use our road system? It's a very, very difficult question. So we thought about it for a bit and he came up with a figure of 70. So he said, maybe 70. We then had in the background, had already spoken to his family, which he was not aware of. And so the producer then said, let's bring in 70 people. And it's interesting because they had a whole lot more people hiding around the back because we had no idea what number he was going to come up with. Anyway, so as you've seen the ad, and it's quite an emotional ad, around the corner walks his wife and his children, his family and his friends. And then he sees that and he sees his family and he says, well, here's 70 people. And the question is, so now what do you think is the acceptable number? And of course, it's 0. Now, that's in some ways a simple message, but a powerful message. And I think what relates then to some of the other conversations we're having today as well is that until it becomes a reality for you, or you're impacted, or you're touched by, particularly in our instance, road trauma, or maybe some bad health outcome from vaccines and some. But until you're impacted, it's very easy for us as a community to leave it to other people. So what we need to do is start to get that conversation, get that debate, get the strong leadership from our leaders to be able to drive the message and make sure that everyone's accountable for what they do. I have some colleagues here from WorkSafe as well in the room, and they're on a similar journey as well. Safety in the workplace is also very important, but it's more than just messages and what WorkSafe can do. Everyone needs to take account for that and be responsible.
Thank you. And clearly, your focus is on preventing injury, death, illness, consequential impacts on both individuals and, as we've talked about, their worlds and their environments, and the impact is on us as a nation and as a system. I think, Rod, you're going to talk about how do you start to influence the thinking in those systems?
Yeah, a little bit. Thanks, Rosemary, and thanks for having me here. So, my name's Rod Campbell and I'm an economist. As an economist, I'm a little bit terrified about coming to a function that's called the economics of prevention. Does anyone here really think, or does anyone here really want economists setting health and immunisation policy in Australia? I certainly don't, because I probably know more economists than just about everybody in the room. And economists, get things wrong a lot, but I think it's really important to think about what economics actually is. Economics isn't a physical science. Measuring economic variables and data, it's not like measuring gravity or periodic table interactions and things like that. Economics is really about putting a number on your own values and your opinions. And I guess it's been a key concern of the Australia Institute for many years that economics and the apparent precision of economic modelling, or the apparent black and white cases that are put forward by cost-benefit analysis, it's been our concern that this apparent certainty, this apparent scientificness, scienciness that economics tends to have, that it's actually used to exclude the community from debate rather than to include people. That economics isn't used to measure community sentiment and make decisions in line with community values, that it's actually being used to exclude the community from debate. And I mean, we've talked a little bit about what I think is a great example, the value of human life. Does anyone know what value the federal government puts on human life? Really? Not a single person?
$4.2 million?
Yeah, I thought it was 4.5, but maybe I haven't checked for a while.
4.7.
Yeah. And do you remember a year of life? Anyone?
Depends on the year.
It's about $180,000. Those values, they've been worked out statistically by doing things like looking at how much more people doing dangerous jobs need to be paid, or how do property values change depending on how close you are to a power station, and so how much more likely are you to die. There's some arguably robust statistical analysis behind some of that, but does it actually reflect community values? Does anyone remember when the yachtsman Terry Bullimore, doing a round the world race, had to be rescued from halfway to Antarctica or wherever it was? It cost us $7 million to go and rescue one guy, and a little bit like what Terry's saying. When there's an individual involved, suddenly that decision's a lot more difficult. And so I don't think that economists shouldn't be involved. I mean, I am a judge in Queensland once described in his judgment in a case I lost, or was on the losing side of, once described me as an evangelist for cost-benefit analysis. Which I'm not sure if I take that as a compliment or not. But I will be an evangelist for cost-benefit analysis if it's actually serving and reflecting community values. And if economics stops being a barrier and stops being about, it's maybe a bad analogy, if it stops being about making the community take their medicine and starts being about actually serving them. So I mean, I think that's a problem with economics in general, and from its very sort of philosophical and logical standpoints. But there's a lot of other problems. Economics as a profession is not in a healthy space right now. Are there any economists in the room? Yeah, a couple of us. Except to be an economist doesn't really mean anything. We don't have a professional standard. No one can strip you of being an economist. It's not like being a doctor or a transport safety engineer or even a plumber, where you are accredited to be an economist. It's not like that. Any one of you can put out your shingle outside your house tonight and say, Rod's economic modelling, come on in, and start taking money to give, arguably, economic weight to your client's opinions. That's a big problem for economics, especially when we have this aura of being scientifically, some kind of scientific discipline. There's a huge amount of economic analysis that is commissioned by interest groups. It's carried out by consultants who have a vested interest in giving their clients the opinions they want. And after all, as I've said, economics is about putting a value on your opinions. There was a third crucial point I was going to make about economics. And I think that relates to whether or not the public service, industry bodies, academics, how well qualified people are to assess some of these economic assessments. If I go away and write you a cost-benefit analysis of including meningococcal strain B and W into the National Immunisation Program, how many people would either feel qualified or B, and this is a big problem, actually have the time to wade through my 60-page report, its technical appendices, and have the confidence that their criticism, when delivered to the decision maker who commissioned this analysis, would actually make a difference. And so, I don't know, would anyone have the confidence that they'd have the ability or time to take on a commissioned consultant like that? I don't think so, but I mean, I've tried to, at the Australia Institute, we try to do it a lot. And it is really tough. It's time consuming, and that's not an accident. This is all about economics being used to exclude people. And key users of economics tend to be people like our government, who are determined to impress upon the community that we can't afford nice things. I was a little bit terrified to hear even such a distinguished speaker describe Australia as a small country, and maybe we can't quite expect the best here. I mean, we have an economy the value of Russia's. We're meant to be as big and bad and influential, or good and influential, as Russia ostensibly is, pound for pound economically. Australia is one of the richest communities living at the richest time in our history. We can actually afford to do pretty much anything. We can't afford to do everything, but we can afford to do pretty much anything. And I think if economists were doing their job better and including the community and reflecting what they wanted, then you'd see a lot more money being put into prevention and vaccines and a lot less money being spent on ridiculous tax cuts for people earning over $200,000 a year, subsidised loans for coal mines, submarines that we're very unlikely to ever use, fighter aircraft that are arguably not very effective, and the huge range of boondoggles that we see all around us.
Thank you.
Well done.
And I hope that's a thank you to all of the panellists, because I think we've just had a fantastic exposure to the layers of issues in this. I started off by saying it's now my view, after 6 years at the Mitchell Institute at Victoria University, where our focus is on how do we improve the health of the population, because by making some of the choices that we've heard here, Australia is letting some of the things that we could pretty much choose to do to sit stagnant and not be done. Poor health, poor employment, poor education, poor everything tracks with socioeconomic disadvantage in our country. And as one of the richest countries in the world, why is that so? To bring back Julius Sumner Miller. It's really important we ask those questions. I've come to the view, and as a long-standing bureaucrat, I've come to the view that the best case I've ever been able to make in the policy-making arena is the cost of doing nothing. And I've made it repeatedly. And I've watched the rollout of good policy and good policy implementation, which is also important, as a result of the effectiveness of that argument. So how do we harness the economics of the costs of doing nothing, the economics of the costs of doing something, the vaccine that will save some lives in the future with long-term benefit to the whole community as well as those individuals? How do we learn from road safety and all the work of the last 30 years, and now the new paradigm of every life is to be valued, not to be discounted? How do we bring that into all our policies? I'm sure you've got some questions. You probably have some comments. Let's open it up. Put your hands up, please, and introduce yourself. Right down the back.
Thank you. Paul Fearon, Victoria's Director of Energy Safety. And if I reflect on our area, or one part of it, electrical safety, which we've seen a dramatic decline over the last 20 years in electrical fatalities and serious injuries, from 20 or 30 per million down to less than 1. A lot of that has been through prevention like TAC. But the and I'm a great supporter on cost-benefit analysis because a lot of it has been justified off that basis and trying to get a hold of the counterfactual. My question is, though, we do have limited resources, and even if you just talk about the health sector, what do economists say about that capital rationing problem? How do you compare, contrast the almost infinite opportunities and claims on the government budget?
Who'd like to comment?
Economist?
Might be one for me. Yeah, I mean, how do you compare and contrast claims for government money? That's a good question. I mean, you can do it with cost-benefit analysis. It's pretty rarely done that way, though. A huge amount of government decisions are not made by informed economic analysis. They're made by political decisions. I mean, I don't know a lot about the health sector, but I think one example of where such a decision is not made, one of my favourites here in my hometown of Melbourne, is why do we have a Grand Prix? It loses bucket loads of money every year, it shuts down a public park, it causes aspects of health impacts and disruption to people. And interestingly, the cost-benefit analysis of the Grand Prix that showed that it is a waste of public resources was also done by the same consultant who came up with the $4.5 million on a statistical life analysis. But we have the Grand Prix. I've given up updating my cost-benefit analyses of the Grand Prix because I've just decided that both sides of Victorian politics have just decided that Victorians like the Grand Prix. And so, for better or for worse, most of our decisions are made by what politicians think the community would like, and economics plays a greater or lesser role in that. But sort of returning perhaps more to the crux of your question, I'd love to see, in terms of how health and prevention could get a better suck of the sauce bottle there, I'd love to see the big spending agencies and the big spending or the industries that are part of health spending within the bureaucracy, I'd love to see them not cowed down and made to talk purely in cost-benefit analysis terms. I'd love to see them come out and say, we need more revenue. I'd love to see, and this is not a role for everyone in the room, but I'd love to see parts of the health community coming out and saying, we need more revenue in Australia. You can't have a Scandinavian-style health system with a US-style tax system. I'd love to see the people in this room out there fighting for the community's welfare, rather than being cowed down and having to justify everything, even in the public arena, with, oh, but can we afford it? Can we really afford to have a great program here? I'd like to see people out there prouder, saying that we're doing the right thing for the community and helping the community understand what they want because, or what they value, because ultimately that's what will have an impact on decision makers in a way that cost-benefit analysis doesn't always have, as the Grand Prix demonstrates.
And that makes it very clear. It's the values question. How do we value what we choose? What values do we use to do the sorting and sifting that you've just raised? Tony, do you want to comment?
Yeah, well, Tony, you go ahead. Well, I think, in a way, the two case studies tonight today do illustrate how economics has been used very effectively to give a rational basis for decision making. The pitch, though, here, at least in the vaccine space, is that we probably could do a bit better with it, and particularly to incorporate the community's valuing of it, that is, willingness to pay in a more effective way, and some of the other arguments around technical issues which relate to economic analysis. And there's no question that it's delivered some level of a framework or an equal playing field for making judgment about the allocation of resources. That's what QALY is all about, a quality adjusted life year, an incremental cost effectiveness ratio, to actually make that judgment across very different interventions and very different health conditions to allow governments to have a basis for some sort of empirical basis. How we put that together, though, is, I think, something we can do much better with than we have before. And I remember the TAC in the 80s, the initial decision that you guys made was really a return on investment. Looking at the projected increase in premiums to cover the health insurance costs of your registration each year was frankly going to be unaffordable within 5 to 10 years, and the TAC made a deliberate decision to invest their resources to prevent that happening. So it was strictly economic. Of course, the health bit of it was in the middle, but it was strictly an economic argument applied to something we all value highly, which is health, and the success of that has been astronomical.
To add to that, I'd just like to make two comments. One is that you really need to take a whole of, in our case, a whole of government or a whole of budget or a whole of economy approach to looking into the costs, because it's not just the outlays that you might pay, it's the whole cost for the community. And it really resonated with me what Rosemary said before, is you need to ask yourself the question, well, what if you don't? So if we don't invest in some of these things, what's the impact? So if we go back and look at road safety, if we didn't invest 30 odd years ago and reduce the road trauma from the 1054 that was the headline back then, you can just imagine how many sort of rehab hospitals and other things we would have, and the impact that would have had on the broader society over those years if we hadn't have stepped in. So I think part of it is to actually start to ask a different question about what happens if you don't, and then balance that off against, well, where are those scarce resources?
Thank you. And I have used Tony's line in our work in arguing for much more investment in prevention of preventable chronic diseases in the country. And not only would road safety have led to no initiative in road safety have led to our hospital system being largely rehab and long stay, would have been really worthwhile investing in crematoria, because that's what we've stopped. And to use Terry's comment, a problem averted is a problem never really understood. So it's really hard to make the case for prevention unless you do really argue strongly what is the cost of doing nothing. And then we've got to go, as I think we've heard today very clearly, the cost to whom and what is it? Not just the cost from A to B, but the circularity of the impact of that investment. Another question, please. Over here.
Thank you. I'm Martin Hensher from Deakin Health Economics. So yeah, I've got a shingle saying I'm an economist. So we talked about the economics of prevention so far entirely in terms of public spending and decisions about public spending on buying product or investing in different things. But there's clearly a very important aspect of the economics of prevention, which is about how many industries currently damage health and make large profits from damaging health. So I'd like to just maybe hear the views of the panel on using economic tools, regulation, taxation, etc., to clamp down on health damaging behaviours.
Who would like to start off?
Okay, this is one of my favourite topics, so get comfortable. No, I'll keep it pretty brief, because there's a great example of everything we're talking about right here in Victoria, on display and open for public submissions right at the moment. Australia is currently considering changing our ambient air quality standards, which, I think I dare say, if you went out and asked the public, is this a good thing? They would probably say yes. The cost-benefit analysis of related to this process has come up with the stunning conclusion that the benefit-cost ratio of some of these measures is about 0.01. So if you think about that for a second, what Oricon, the consultants to the Victorian EPA, have crunched their numbers and come up with the idea that air quality measures that are in existence in almost every other developed country are actually 100 times more expensive than they are worth. No one seems to have questioned this conclusion that every other developed country government is off their rocker. But this is what's out there, and they've made some pretty, I would argue, pretty obvious errors. One is that they've calculated the capital cost to each power station of retrofitting their entire operations and compared that to the benefits of an ambient air quality improvement without considering the benefits to the people who might live next door to those power stations, who, medical health experts would know better than me, are probably more likely to feel those benefits. Here's a great example of a terrible cost-benefit analysis that is on display with easy errors, and their discount rate of a whopping 7%. I find staggering. The government can borrow money at less than 1%, and yet we're discounting future lives in a Victorian EPA process right now at 7%. So I feel like I'm now ranting and I can't remember what your question was, but...
It was how to work it so that won't happen. We need to know how that ought not to. What tools can we use to stop that happening?
Well, I would say engagement in the process and a desperate attempt to call out econobabble and poor analysis and urging, there's a lot of very powerful organisations here today using their voices to urge decision-making in line with the community interest, not just based on a technical appendix of a commissioned report.
So the values case against the technical argument. Terry, Tony,
I'll
your
just
comments.
that's a very pertinent and insightful question, but in a way it links to the first question too, that the vaccines illustration is an illustration of a strong empirical method to give you a rational basis for decision-making based on evidence. And it hasn't been applied to other preventive interventions, including those interventions which might look upstream at the determinants of adverse health events. So we have a medical benefits schedule, which it has its own decision framework for deciding what the costs will be under Medicare of medical services, the PBS for drugs and vaccines. But for other interventions, for example, the potential benefits of taxation on sugary drinks or other foodstuffs are a very hotly debated issue in Australia, and you'll notice in the UK, Boris has just said that they're going to dump a demonstrably very successful sugar tax in the UK if he's elected Prime Minister or appointed Prime Minister by his party. But we don't have the extension of your argument for in the first question of this framework beyond some of these very good examples of empirical basis to assist that decision making, as imperfect as it might be. But nonetheless, we've got ourselves organised to do that. Why aren't we doing this in a much broader way across all of the things that we do in our public expenditure?
And I guess from my point of view, I don't really have an answer to the question, but unless you can engage community sentiment around a particular issue, whether it's smoking or other things, and we've seen that over the years, how that's changed, you can't really change behaviour, because it'll always come down to an argument about scarce resources or wanting to hold your seat in Parliament and those sorts of things. So until you can get the community behind and the voice of that community almost demanding change, you won't get that change. And I guess climate change is probably a good example of that, because the debate is still raging and there's so many different views and the facts aren't that clear. And until we get those facts clear and when people understand, you get that common understanding of why it is important, then we won't make change.
Thank you. I think we have another question over here.
Kristen Trace McLaren from GSK. It's come up quite a bit that economics can feel opaque and technical and inaccessible, but yet on the other hand, we can't de-link it from what the community wants and values. And that's, I guess, to your point just now as well. And I guess my question is, how do we resolve that? Because these are really useful decision-making tools that government relies on. We don't necessarily want politics to play the entire sort of decision-making in isolation of economics. So how do we bring in the community into that fold in a real way, potentially better than we do now?
John.
Well, I guess the key to that really is stronger community engagement. Last year we had the lowest road toll in the history of the state, which was fantastic. This year, unfortunately, it's 50% above. We've had 164 lives lost already this year. And what we're doing to counter that, because again it comes down to the individual's choices they make, is we're getting out into the community and running forums to try and engage the community, get everyone in the community engaged in the conversation. I think one of the things I've learnt over the years is that if you can have a engaging conversation and get everyone involved and debate it and give people the opportunity to put their case and what their concerns are, you often come out with a better outcome. And it's the only way to do that is to get everyone behind that and support that. And it's not easy. And I think if we look back to my previous example of Sweden in 1997, for them, for the whole government, to have a debate in Parliament about the value of life is amazing. And we probably need to get to that. How we get to that, I don't know, but that's what we need to aim for.
I can be really quick on this one. The Australia Institute has long argued for a code of conduct for economic modelling, and you can check that out on our website on what we think should be in that. Not that I think that would ever become law anytime soon, but I think public support for that from treasuries and governments would be really important. I think there's a couple of other things that could easily be done, and one is build capacity in the public service. I'm routinely shocked at the various public departments' inability to conduct their own cost-benefit analysis or critique anyone else's. In New South Wales, in their planning department, you have the extraordinary situation where in the approval of a coal mine, to come back to your question of how do we clamp down on industries that cause public health problems, in the New South Wales planning system, the economic case for coal mines is not assessed by the planning department, it's assessed by a consultant that's paid by the mining company. After many, many battles in and out of court over that exact problem, the department has now started not properly critiquing these, not doing their own assessments, not properly critiquing these assessments, but hiring their own consultants to critique the mining company's consultants. And in some cases, the then decision-making body even commissions another consultant. So returning more economics capacity to the public service, I think would really help. And something that could contribute to that would be returning economics into undergraduate and postgraduate courses. There's a lot of commerce degrees where, from what I understand, I mean, I had to do 3 years of economics in my undergraduate degree. My understanding is you can now get a commerce degree from the University of Melbourne, I think, without anything more than first year micro. I think that's a real problem. So they're three quick ideas from me.
Very quickly, the Melbourne Institute for Social and Applied Economic Research is a well-known entity, does similar things to CEDA in terms of engaging with the community, the business community and the general community. The tagline on the Melbourne Institute is hard heads, soft hearts. So without science, without compassion and without understanding what society is about, you can't have rational decision making. Hence the point before about this, again, this willingness to pay thing. As you said, Rod, economics is not just about counting numbers and making economic arguments. It's about the translation of community perceptions and values into a quantifiable format that allows us to make decisions about things. And therefore, I think it's a wonderful thing that we should be doing more of and applying it more broadly in the community. But equally, just to go to the point too of how to get people to listen, I saw enough of advice within the government in the vaccine space to know that special pleading and advocacy based on individual situations is not a very powerful motivator for government. You can have that, but it has to be linked to a stronger argument that wraps up all those other things that governments feel they're responsible for, but they must be linked.
Wow, that's fascinating.
And I would add to that from my own experience that we need community argument and community expectation to be built. And if you think about the more recent policy change in Victoria towards voluntary assisted dying, regardless of one's opinion, and that's not the issue, that's been led very effectively by government. Government has listened to the voices of people who have been working towards this end for a long time. And now government has led the public towards it and is doing a really sterling job, if you've been getting stuff in your letterbox, about engaging every single person in understanding why that new legislation is in and how it will work. That's what we need, but we don't get it easily without community engagement. And community engagement, in my long experience, both as an administrator and now as a thinker and advocate, comes from those who have the knowledge, and you're all here. It comes from the sectors with vested interests who can step outside that interest and say, objectively, this matters to everybody. We'll benefit, but it really matters to everybody. It was the surgeons who said, let's stop road trauma. They were willing to do themselves out of work. We have to have that. We have to have it from industry. We have to have it from commerce. We have to have it from public servants. We have to have it from those who have the knowledge. And if we step aside and expect somebody else to do, then we will wear the consequences. I think we've heard a fantastic presentation and discussion today. Thank you all for participating. Can I ask you to thank the panellists? And I hope you will take away a strong message.